Good afternoon and welcome everybody. I'm Kim McGrail and I'm the Director of Research at UBC Health and a professor in the School of Population and Public Health in the Faculty of Medicine. Thanks for joining us today for our next session in the Health After 2020 dialogue series. Before we start, I'd like to acknowledge that the UBC Vancouver Point Grey campus is located on the traditional, ancestral and unceded territory of the Musqueam people. And the UBC Okanagan campus is located on the traditional, ancestral, and unceded territory of the Syilx Okanagan Nation. I'd also like to recognize that UBC's activities take place in community on the unceded, ceded, and traditional territories of 203 First Nations and 38 Métis chartered communities, each possessing their own unique traditions and history on the land that we refer to as British Columbia. Today, I'm joining you from the traditional, ancestral, and unceded territories of the Coast Salish people, the Squamish, Tsleil-Waututh, and Musqueam nations. And before introducing our speakers, I'd like to just make a few comments about UBC Health and the Health After 2020 program. The UBC Health works under the Office of the Vice President of Health, and we recognize the growing need for collaborations to address complex and interconnected problems facing society. We facilitate collaborations across disciplines, faculties, and campuses, as well as with health partners and communities. Our work enables us to improve the ways we collectively train people, how we develop knowledge, and the ways that we can shape policy. Our ultimate goal is to address inequities and improve systems that foster and support health. Through our initiatives, we aim to foster an active community of health research practice and mentorship. The UBC Health Dialogue Series brings together scholars, students, and community partners to discuss important topics related to the health and well-being of society and to advance interdisciplinary knowledge translation. Our understanding of the determinants and experience of health and well-being has changed. In 2020, the COVID-19 pandemic accelerated some existing trends and put a spotlight on others. And we're now responding to the broad effects of the pandemic, hopefully in more positive ways. We have the opportunity to learn from our collective experience and to think differently about how we define and value health, how we understand the complex systems that produce health, and how we rise to the challenge of supporting equity in health across individuals, communities, and societies. So in response to that opportunity, UBC Health developed Health After 2020, a program designed to support researchers to engage in interdisciplinary collaborations and to build a community of UBC Health scholars. Through the development of research collaborations, academic outputs, cross-campus conversations, and open dialogue sessions, the program convenes and informs people at this inflection point in our society. 8 interdisciplinary teams have been funded during this inaugural year to advance and disseminate their collaborative research, which includes leading a dialogue session, and that brings us to today. So our dialogue session today is titled Branches of the Same Tree, using linked administrative health data to reduce illicit drug poisoning and improve the health of people released from incarceration. The session will start with an opening by Sarah Cadeau, who's a knowledge keeper, and then will be moderated by Amanda Slonwhite, who's an assistant professor in the School of Population and Public Health and in the Faculty of Medicine and a senior scientist at the BC Centre for Disease Control. Our other speakers are Stuart Kinner, a professor of health equity at Curtin University in Australia, Mo Kraczynski, executive director of Unlocking the Gates Nonprofit Society, Heather Pallas, who's a postdoctoral fellow in the Department of Psychiatry in the Faculty of Medicine, and Sophia Bartlett, who's an adjunct professor in the School of Population and Public Health and senior scientist at the BC Centre for Disease Control. So please welcome Sarah to start us off.
Miigwech. Thank you so much, Kim. And welcome everybody. I just want to take a moment to say bonjour, anin, indishnakas ikwe, amamingo batut ochin ganan, mitnask dodem, kirigan zibi Ojibwe Ontario First Nation, and Jaba, Anishinaabe Kwe, Celt, French, and Ashkenazi and Dao. I just want to offer a prayer and a welcoming and to also state my gratitude to be a dual citizen. I am Anishinaabe from Ontario, but also was born and raised and returned back to Coast Salish territory. I also want to acknowledge that I am currently on the territories of the Parasuas people, also known as Baja California Sur. I just want to ask for a moment to have everybody ground and center into this incredible opportunity to do work between the highest levels of science and academia, and also our cherished lived experience experts who are here today on this panel. and for the work that is being done in often in places that are not given this kind of funding or celebration as much as typically white-held academic institutions are. And so I really want to acknowledge that this is an opportunity for intersectional healing and to bring equity, which I love that that was used so much, Kim, in your opening, to really understand that the work that's being done on the street, as somebody who has lived experience with incarceration and substance abuse disorder myself, as well as the trauma that led me to those places, you know, that we have people here on this panel who are literally walking in places where demons fear to tread. And so I want to offer my prayers of gratitude, not just to the academics who are allowing themselves to understand that the institutions they are part of have been problematic, specifically for the populations that surveys and workshops like this and seminars like this are supposed to serve. And I also want to acknowledge that we have a beautiful group of people who are walking in those areas every day. And so I want to raise my hands to all the assembled experts, but also to those who are in our cohort who have signed on and those that are going to be listening, to continue doing this good work and to continue leading with your heart and to continue asking yourself, how can I be of best service for the world that I want to see and leave to the next 7 generations? And so I want to acknowledge that teaching, that we walk for the next 7 generations and give thanks for the people whose land we're on. And also, I always ask that the work today that's done benefits those people whose lands we are on, all my relations. Have a beautiful workshop, and I'll see you at the end.
Great. Thank you so much, Sarah. Really appreciate you being here and opening us up in a good way. And so today we are going to have a dialogue. It's going to be less about presentations and more about a conversation. And so we have our 4 panelists here today, and we're going to be posing a series of questions to our panelists for them to reflect on and also highlight some of their programs and research and observations. For the audience, if you have questions as we go through this conversation, please put them in the chat, or you can send them to me directly, and I will pose them to our guests as we go through this dialogue. So thank you. And so Stuart, Heather, Mo, and Sophia, it's great to have you here today. And we're going to start with the first question being, what impacts has COVID had on the experiences people have after release from prison? And perhaps, Stuart, you'd like to start us off with some observations globally?
Yeah, thanks, Amanda. And look, just to say that we knew before COVID that our global prison population was just increasing year on year, and perhaps more concerning that the incarceration rate is increasing globally year on year as well. So we're going in the wrong direction. And although women make up a minority of the prison population, that's a growing minority. So there's changes in the profile of people who experience incarceration as well. As you can see from this PRI slide, the latest estimate is that we had 11.5 million people in prison in 2022, and that's on any given day. So the number of people moving through prisons each year is a lot higher. One estimate is about 30 million, but we just don't really know.
And so maybe Sophia, Mo, or Heather, you'd like to talk about what we've seen here in BC during COVID.
Yeah, I can start us off. So at the beginning of the COVID-19 pandemic in the provincial system in BC, we did see some initial efforts to divert people away from custodial sentences. So that means that instead of the court choosing a period of custody for someone who's found guilty of an offence, they were more likely or trying to sentence them to periods of community supervision. And so this was a strategy that was being employed kind of with the mindset of if people don't need definitely to be in custody, then during that period like COVID, where there's a respiratory infection circulating, that they could divert them elsewhere. And that did have an initial impact in reducing the number of people being admitted. But as you can see in this figure, it actually leveled out really quite quickly. And so we didn't see sustained decreases in the number of admissions. And it seems that the number is starting to creep back up again. And we did, I think it's worth noting, there was some sort of falls in the number of admissions from 2016 onwards, but it's not a significant one. And we also know that people in the federal prison system in BC and across the rest of Canada, we weren't seeing decreases in the number of admissions or increases in releases from the federal system. Mo, did you want to maybe comment on sort of what you experienced in terms of people coming out of custody at the beginning of COVID?
So at the beginning of COVID, speaking of March 15th, 2020, when, the world shut down and we mass released everybody, you can see the big drop there. Everything shut down. There's shelters shut down, treatment centers shut down, all services shut down. And we were mass releasing individuals with nowhere to go. They couldn't get back to their communities. That's where, my organization, we never stopped working. We were driving people back 10 hours back to their communities, 14 hours some days. And the other big thing was people come up with nothing. So it's not like we could take them and go get them clothes at a, secondhand store. They couldn't get onto welfare. They couldn't get medication. Things shut down. This population don't have phones. So it was a big barrier there too. My staff was, unique. We reached out to all our friends. We needed clothes, so we'd have a truck full of clothes. People come out with flip-flops in the winter because they were arrested in the summer, right? No jackets, nothing, none of the basic needs. And it really highlighted whenever the world shut down.
Thanks so much, Mo. So Stuart, you guys saw something similar in Australia.
Yeah, Amanda. So I suspect that similar patterns have arisen in lots of different countries around the world. These are some data from New South Wales, which makes up a third of our prison population, and it's month by month data on the prison population, just showing this quite precipitous drop after we started responding to COVID around the beginning of March 2020. So that looks like good news, but if you move to the next slide, I can show why it's perhaps not as we thought. There was a concern that reduction in incarceration was not consistent across subgroups. And indeed, we know now from Australia-wide data that firstly, the reduction in incarceration was mostly among non-Indigenous people. And it was largely a function of court discretion rather than any kind of systemic or legislative change. And secondly, you can see even by 2021 that things came back up. So because we were mostly getting people released onto bail rather than being held in pre-trial detention or remand, we're kind of just kicking the can down the road. We weren't changing people's trajectories. We were just delaying their experience of incarceration. So it's kind of been a bit of a blip rather than anything that's a profound change.
So Sophia, I know you've been doing work in provincial corrections here in BC. Have you seen similar observations?
Yeah, so we definitely saw that when we were conducting studies in 2021, which was looking at the prevalence of COVID infection among people in provincial custody, and then in 2022, looking at attitudes and beliefs around COVID-19 vaccines among people in provincial custody. We saw that there was a higher than what we expected proportion of people who identified as Indigenous. And one of the ways that we sort of interpreted that was sort of thinking that potentially that was impacted from court decisions, and that maybe they were more likely to have been diverting people who were non-Indigenous to a community sentence and people who were Indigenous more likely to be incarcerated. We don't actually have similar data to kind of what Stuart showed to actually see if that's the reality or not, but we definitely did see a higher prevalence of, or a higher proportion of people who are Indigenous during that time. And I think when we were talking to people about what their experiences were during that period in custody, especially in 2020 and 2021, we heard really a lot of the same types of fears that people in the community had, but really that there was a heightened type of anxiety that they were experiencing because of the additional layers of, I would say, isolation and restrictions that people had. So, these are some quotes from participants in the advanced study, and I think really speak to kind of the way that people who are incarcerated were experiencing this. And I think that very top one, even for a career criminal or someone hardened by the desensitization of emotions, I was scared when I tested positive for COVID-19. I think many of us in the community have tested positive for COVID-19, and while we might have had some concern, we had the ability to Google our symptoms, and we also had the ability to connect with a care provider really quickly. And that's not the case when you're in custody. And so people who are in prison during this time have had a really different experience. I think also kind of heightened and really contrasting what we heard in the community, people talking about, being on isolation or quarantine like they were in prison. But the reality is that that was nothing like being in prison during COVID-19.
So what I'm hearing is we saw a widening of the existing inequities of the criminal legal system, that the continued disproportionate incarceration of Indigenous peoples, and then also just increased stress and mental health issues among people who were incarcerated, who were also very scared about the COVID-19 pandemic. So turning our eye here to overdose, how has COVID-19 affected our approaches to preventing and responding to overdose after release from incarceration? And maybe Heather, you would like to start us off here with some observations from BC.
Sure, thanks, Amanda. So I think many of you are probably familiar with this slide, but it's just to help situate us relative to the context that people in BC are released back to when they're coming to the community in the context of COVID. So you can see that there was sort of a slight decline in illicit drug toxicity deaths in 2019, but that has continued to rise in the context of the pandemic. And in 2021 and 2022, we actually see twice the rate of illicit drug toxicity deaths in BC as we did in 2019. And we do know that people who are released from incarceration are disproportionately affected and at risk of overdose, particularly in the weeks immediately following their release. There are a number of reasons for that. In particular, if we're thinking about interruptions to health and social networks, and also thinking about tolerance being lower if people are not using opioids or other drugs in correctional centers and then are returning to the community and starting that use again. This next slide is thinking about one of the major components to increasing overdose risk in the context of COVID-19 is the changing illicit drug supply or unregulated drug supply. So this shows very well that the blue line of fentanyl has been really stable in terms of contributing to overdose risk for the past several years. But more recently, we've seen not just the detection of fentanyl, but the detection of extreme levels of fentanyl rising among people who are dying. So that's really telling us that the potency of the opioid supply has changed, and that has elevated risk of overdose. A couple of other pieces that are important in thinking about changing drug supply, if we look at this purple line, over recent years, methamphetamine use has been increasing. Many people are using both opioids and stimulants, but we don't have a good range of treatment interventions or supports for people who use stimulants. And then also this orange line, we're seeing more benzodiazepine contamination of the drug supply, and that's really challenged overdose response because, like opioids, benzodiazepines also depress respiration. And so that can really create challenges in responding to overdose. So I think really considering the fact that people are accessing an unregulated drug supply is important in thinking about the drivers of death.
Can I just add something to that?
Absolutely. Yes.
I do a lot of work with people on, people in active addiction and, talk about fentanyl and, they know that, every time they use, there's a chance that they could OD. And, their response is, but there's no high like it. Right.
Yeah.
Right. I mean, they love the fentanyl, and that's the problem, right? How do you get somebody to even want to come off of a drug, what they love, right? And then the scary part is too, it's another high is the overdosing. People want to overdose because there's such an extra high in that as well. What is even, super scary, right? So it's really hard to change this downward when that's all people want, right? Because there's nothing like it.
So in the context of COVID and the increased contamination of the drug supply, I know all of our panelists have observed some changes to services. We've also seen some changes or there was an effect on harm reduction sites. And so Heather, I'm not sure if you would like to talk about this, or Sophia, in terms of we saw a decline in use of overdose prevention sites.
Yeah, maybe I'll just quickly speak to this slide, and it's really meant to just be an example, a very clear example of the interruptions to care in communities. So people are released back to community and perhaps used to be in contact with overdose prevention services or supervised consumption sites. That was access to a place where they could bring their drugs. And if there was an overdose event, someone is there who's trained to respond. But it also provides sort of a social network of support that, having an interruption to that care service means people are also possibly more likely to be using alone. And that's another risk for overdose. So I think the service interruption and social isolation go hand in hand, and maybe I'll pass to others to speak to that.
Yeah, I think we also have seen similar kind of decreases in testing for sexually transmitted and bloodborne infections. So it's just another example of the way that people's interactions with care changed. And it's, from a health systems perspective, it has been sort of something that's been difficult for us to kind of unpack because, for example, for, STPBI testing, there wasn't in all situations actually services closing or saying, that they couldn't see clients. And yet we saw the testing rates just plummeting. And when we're sort of then contextualizing, what's actually happened, talking to clients and users of the services, we're then starting to understand, the message from the health authorities and from the public health response was to not seek care unless it was urgent or an emergency. And that message was really taken to heart by people. It was like, stay home. And so, while a lot of overdose prevention services might still have been open in some way or another, the message that people was getting was actually kind of contradictory. And so I think this really needs to be a big learning kind of opportunity for us from a communications perspective around, how do we manage that type of messaging while also then ensuring that people are actually accessing really kind of essential public health services like overdose prevention sites or, take home naloxone or HIV testing.
And so, Sophia, would you like to talk about the work you've done with people who were incarcerated during the pandemic and the impact of that isolation on their mental health and substance use?
Yeah, I think one of the things that happened within the correctional system or within the criminal legal system across the world as a response to COVID-19 was essentially trying to lock the prisons down. So they wanted to minimize as many people coming in and out as possible in order to reduce the likelihood that COVID was going to be introduced and then spread throughout the correctional centres. And, this makes sense. It's a pretty well-established practice. It was the same thing that happened in the long-term care facilities. And, we're increasingly starting to understand that the impact of that, while it might have reduced the likelihood of COVID getting transmitted and protected people from getting infected, it actually caused other problems, particularly in terms of people's mental health and emotional wellness. And we're hearing a lot about how people in long-term care facilities were incredibly distressed and anxious and lonely. And the exact same thing was happening in correctional centres. People who were testing positive for COVID in many cases were actually held in segregation or isolation because there was no other place that was able to be used to isolate them. And so, what's usually used as a behavioural management strategy or a punishment was actually being used as a kind of health strategy, and really that has detrimental impacts on people, but also just people who were being held in the normal kind of cells that they would be in on the living units. They were experiencing a lot more social isolation than they would usually experience, and programs and things that were intended to help rehabilitate them were all suspended. And so people talk about particularly the lack of programs being detrimental to their mental health, but also just being isolated and really, not having access to people to talk to, and having limited time out of their cells. And I think, Mo, you could speak to this. A lot of people who were having to kind of make the decision between, do I have a shower today, or do I try and make a phone call to try and organise supports for myself when I'm getting out of custody in a week or two? It's a really hard choice for people, and I think really contributed to that anxiety that people were experiencing.
Yeah, and a lot of people, a lot of services are only open till 4 p.m., and some people weren't getting out till they get out 1 hour. And, sometimes it's 7, 8, 9 o'clock at night. And, that's one reason why Unlocking the Gates has our phones on from 8 a.m. to 10 p.m. just for that reason, because people don't have access to a phone all the time. And majority, and a lot of people don't answer their phone. They don't accept correctional calls so they can't get a hold of services. So, us being that lifeline to be able to connect people to the, to the real world out here. But yeah, it was a struggle, 7 o'clock at night, and I'm like, okay, can you phone the intake office? And they're like, I can, I'm only out at 8 o'clock. So it really expanded our job to make sure that everybody was having a safe release plan as much as we could.
And Stuart, have you seen this observed in Australia as well?
Yeah, look, I think the response to COVID was heavily about infection control, with probably insufficient consideration about mental health and well-being and social connection. And I think it was partly driven by the fact that, early 2020, we thought this was a passing thing, we'll just lock down for a couple of months and then we'll come out the other end. And it ended up being a very sustained issue. And, it took, certainly even the more progressive correctional authorities in Australia took a long time to even begin to respond in ways to mitigate those harms through things like iPads to maintain family and professional visits and things like that. So, these are all things that could and should have been in place before COVID ever emerged in the first place. So it's been, it's really highlighted some resolvable deficiencies in our systems.
And I agree with that in BC too. Like, the visits started to be going on tablets, right? I thought, genius idea. Phone calls were free. You didn't have to have money, right? But they ended that, right? So now people have to have, $2 on their phone card to make a phone call. And they stopped doing those visits, and when you're spread out like BC is, you people who are, especially the women, we have one women's prison, what's, down in the mainland, and you got people like 400 or 500 miles away who don't have that chance to visit with family. And it's actually gave an opportunity for people to connect with family. And I'm sad to see that we've stopped doing that. And I thought it was a genius idea.
And the people that participated in the advanced study also thought it was a genius idea, Mo. So there was really high acceptability from people, and really a lot of enthusiasm towards having more social connection, which we know is associated with more positive mental health and wellness. So, we heard from people who are incarcerated who were actually actively trying to come up with strategies for themselves to improve their wellness, and having those phone calls really helped. So there are some kind of really beneficial things that can be in place, and I think we really should think about how we can foster and continue those. And again, to Stuart's point as well, those things should have been in place before COVID. Like we should have really, it was 2020. We were all talking on video phones, you know, you can be in the middle of anywhere and have access to that type of thing. So that really should have been in place. It's great that it's available now, but there are also still correctional centers that don't have access to that.
And how many people actually connected with family and children what they haven't for years? And, you know, I don't hear it as often now when we pick up people, but, you know, through the pandemic, especially the first 6 months, you know, so many people like, I haven't talked to my mom in 5 years. You know, it gave people an opportunity what wouldn't, you know, reach out to family, an opportunity to do. And that's so much healing and so much hope for people when they're getting released, you know, that they have that connection to their family or to their children. And we've sort of taken that away again.
Absolutely. So the third question we have is, what do we need to know about the health of formerly incarcerated people, and how can we find out internationally and in BC? And this is a very large question. We've had a lot of pleasure to work with Unlocking the Gates and a group of people with lived experience who are co-leading some analysis of the BC Provincial Overdose Cohort. And I think really show the importance of engaging people with lived experience. And so Mo, I was wondering if you could take a moment to talk about UTG and maybe offer some reflections on the partnerships you've had with us at BC CDC.
So Unlocking the Gates, we've been around for 16 years. So we're 100% peer-led, from my board to me. I have prison experience and all my staff. For us, we really knew when we started this program how much it would have benefited ourselves when we were released to have somebody on that outside of the gate and have somebody there you could call and just have a conversation and say, you know, I'm scared about getting out. I don't know what to do when I get out. And build those relationships and that trusting relationship before they get out. And, you know, and the biggest one is floating and giving hope and dignity the day somebody gets out. What I never ever had experienced when I got released. We work with all the correctional centers in BC. It's a pretty big province, but our goal is, you know, it's definitely changed over the last 6 years with the overdose crisis, is making sure people are going to survive those first couple of weeks out. Like I said, people get out, they have nothing. They have dirty clothes, half-time no shoes, no jacket, you know, a clear plastic bag with their personal belongings. The chances that they're going to not go back to the street, when I always say we unlock the gate to the prison, but not to society, right? And as UTG, I want to be able to open those gates, you know, walk with somebody who has to go to a welfare appointment and be treated with dignity because my staff's there, or to a probation officer, you know, with dignity. So yeah, and again, and offering them like, hey, you know, I've been there, I've done it, I know what it's like getting out of prison, you know, and they're like, well, how did you do it? You know, you're driving a car, you know, you know, how do I get into doing? Like right now I have 2 staff, but we actually were clients of ours, but now work for us, you know, because people are like, I want to do what you're doing. All right. And I'm like, hey, stay out of trouble for 2 years, stay clean for 2 years, you know, reach back out to me. And they do reach back out to us. So yeah. And, you know, and then from after COVID, one of the biggest ones was everybody got out on conditions. Everybody got out on bail or probation. We've seen a huge number of people who had warrants because they weren't compelling, you know, they couldn't make it to their appointments or probation. So we started a warrant and bail resolution program where we work with people who have warrants. We connect them to legal aid, we connect to Crown, and we make sure that, you know, that they're not going to get arrested. You know, with our support in the community, it's been super successful. I think this year we've done 243 clients. We've only had 3 who've actually gone to jail, and they all knew they were going to go to jail before we even took them to court. Probation, our clients who are getting 6 months probation are finishing their sentences and their probation orders in 6 months, because probation officers will reach out to us and say, hey, Jill didn't sign in. Can you get her to call me in or bring her in so I don't have to breach her? Being super successful. Again, it's going to take a community to do this. We can't do this work unless probation helped us, and, you know, Crown working with us and saying, yes, hey, bring them in, or, you know, lawyers and having community support. So
thinking about the past year, we've been working really closely with the BC Provincial Overdose Cohort. Maybe some reflections. And Heather, you've also been co-leading that work with Mo. Any reflections on that? Because we've had access to this rich linked admin data to be able to pull statistics and pull information. Any thoughts on that?
That my heart still breaks every night I go to bed, knowing that 8 families are going to be devastated because their loved one died. And it doesn't change. It's every day. You know, it's hit close to, you know, to me personally, you know, my team. We just need to do something. We need to do better. And
Heather, any thoughts on the co-leading of the work with the Provincial Overdose Cohort?
Yeah, so we, for about the last year or so, Amanda and I, alongside Mo, have been co-leading some work, bringing together a group of people with lived experience of incarceration to advise on research priorities for the Provincial Overdose Cohort. So really just came to that with coming from a place of, this is the data that we have and what are the priorities. And I think it's been really valuable to be thinking about driving our analyses and our outputs directly from people who have lived through this. And it helps with thinking about the relevance of recommendations that we can put forward. And I guess just speaking to the slide that's up there right now and kind of going back to the conversation that Mo was having about what Unlocking the Gates does and meeting people where they're at. Something that our team has been working on kind of promoting is Unlocking the Gates and peer-led interventions, because, you know, we can build up all of the interventions that we think are effective or want to be effective, but if people don't feel safe to come to healthcare, then they're not going to have any impact. So I think what you know, organizations like Unlocking the Gates do is all of these pieces around building relationships, meeting people where they're at, providing consistent support and offering hope. It helps people feel safe to re-engage with a system that maybe they haven't been comfortable to do. A key learning for me out of all of this work is just having more of a focus on the role of people with lived experience in driving connections to care.
Absolutely. Sorry, Mo, did you want to add?
I was actually going to get Sophia, and then we can see that with the TLC program. Absolutely. You know, having that peer support, and you know, and the success rate, and you know how successful it was on this. And I'll get Sophia. You can talk about it. So,
in respects to people who are living with chronic hepatitis C infection, we have, from linked administrative data, been able to identify these particular population groups which have the biggest gaps in terms of accessing curative treatment. Hepatitis C is the only chronic viral infection that's curable. We have really, really effective medication now that actually clears almost all infections in just 8 or 12 weeks. But we saw from the linked administrative data that people who have experienced incarceration, people who inject drugs, and people who are homeless, and often actually all three of those are the same kind of group of people, that they're the ones who are actually inequitably kind of being impacted by the health system. And often they're being labelled as hard to reach. But the reality, when we're actually discussing with people who have that lived experience, is that they're not really hard to reach at all. And, you know, Mo's talking about finding people who have warrants out on them. They're not able to be found by the police, but somehow Mo can find them. So I think we really need to challenge that idea that there are people who are hard to reach. It's actually the services and the system that's hard to reach. And TestLink Core Project is an example of a peer-led model where Unlocking the Gates peer health mentors are able to identify people who know that they have a hepatitis C infection and provide them a cell phone that has a free plan on it, paid for 6 months, and then actually coordinate with healthcare services for that person to access hepatitis C treatment. And we've seen now really actually great outcomes after a year of the program. The Correctional Health Services team actually identify clients and help them do the intake before they even get released from custody. So we now see actually much better continuity for people transitioning out of custody, either already on Hep C treatment or actually waiting to start because they were on a really short sentence. But also now we're seeing unlocking the gates, actually reaching people who might not be engaging in care, for example, because they have a warrant out on them, and are able to then support them to access treatment. And this is, to Heather's point, a really good example of how we can identify really quite simple and tangible types of interventions by working with people who have lived experience, because this project we developed together and figured out, how it was going to work, what were the types of training that the peer health mentors needed, and also just being able to be flexible and to be creative to come up with those solutions. And we're also using data then to kind of drive our evaluation and interpreting the data together, which I think is the next point, right? Is we can have the best data in the world. We can have the biggest linked administrative data cohort ever. But if we don't actually really contextualize those individuals within the data, we're kind of only just getting the tip of the iceberg. And I think that's where we actually can use data to its strongest ability, is when we work with people like Mo and other people with lived experience to actually then, put faces and put stories to the data. I think that's where we're actually going to be able to really reach people and come up with those kind of transformative solutions.
Absolutely. And I know, Stuart, in your in the Health After 2020 project that we've been talking about the increased use of partnering with people with lived experience across the globe in this area. And I know this is a priority for you, I think, around youth analysis and contact with the criminal legal system.
Yeah, it's been something we've been trying really hard to get better at, and I feel like we can always get better at it. But so we've been doing some national data linkage of youth justice records with various health records in Australia, and it's really been, we're still learning about the incredible ways in which projects are better if they're a genuine partnership with people with lived experience. And it's not just about, how to design a study or how to do the analyses. It's a reminder sometimes that the numbers that we get in these massive administrative data sets, each number, each cell in this massive database is an experience that a person had. And when you have people who've had those experiences reflecting on what it means and what it doesn't mean, it doesn't just enrich the data, it can sometimes profoundly change how you think about them.
I think this is a good time to turn to our last question. What should be done now and into the future to improve the health of formerly incarcerated people in BC, in Canada, and across the globe? And I think this is really our opportunity to highlight what's coming or what we foresee coming. And maybe, Mo, this is a good place for you to start, maybe, in terms of what you think needs to be done and what we need to know and how we work to achieve that.
Oh, there's so much.
I know.
And I think I'm not sure any places, but we also know, we have a housing problem. Housing first is huge. You can't expect somebody to be released from corrections and, so many people are homeless, no clothes, no food, no shelter. The basic needs, what we take, most people take advantage to be able to walk into their house and be warm, go to bed in a soft bed. So many people being released from corrections don't have that option, right? There's not enough treatment beds for people to go to if they want to, and I think also what needs to improve on our health. And I think, Stuart, you said the same thing. And so see if you ask the people what are getting released, what can we do to be better? It is a community issue. This isn't just people who, people who work with people who are homeless or people incarcerated. It's a global issue, right? Mm-hmm. And it's everybody who lives on this planet's responsibility to make sure this population has what they need. And we're not doing a very good job. I say it takes a child to, community to raise a child, but it takes a community to support somebody who's coming out of corrections or somebody who's homeless and how to for them to turn their life around. And I think we can do a way better job than what we're doing. So yeah, and I think just ask formal. I mean, I could tell you exactly what we need. People need safe housing when they walk out that door. They need clothing, they need dignity, they need hope, right? Everybody needs hope. they don't have much hope when they get released.
Yeah. Stuart?
Just building what Mo said there, I think one of the themes that we're exploring in this dialogue session is around administrative data and how that can be useful here. And I think one of the things, Mo, I think that you were getting at there is to have a person-centered rather than a system-centered way of thinking about things and asking people what they need. And it's not just the mental health system or the drug and alcohol system or some other system. And, you know, that to me as a researcher, that really aligns well with using administrative data, linked administrative data in constructive ways in partnership with people who have lived experience to try to come up with a more comprehensive understanding of people's experiences, their strengths and their needs, rather than saying, okay, I'm going to treat this issue or that issue and being kind of myopic about it.
And maybe to rely less on those data sources we have in the past and to pursue new data linkages related to housing and economics and supports after people get released, which aren't as frequently linked as health systems data. Heather, I'm wondering from your perspective, especially in relation to overdose and linked admin data, kind of what do you see kind of coming? What needs to be done now and into the future in terms of research?
I guess just picking up on Mo's point around going back to the community and bringing this conversation back to overdose and the drug supply. In BC, we have a decriminalization pilot, which is great, but for many people, the drug use is still criminalized. Even the movement towards decrim doesn't change the fact that the drug supply remains unsafe. So, you know, if we're looking to the community, calls that are being made are for a regulated, safe drug supply. So for me, that is critical to moving away from the illicit drug toxicity crisis, is moving away from reliance on illicit drug supply. So doing more work in that realm of safe supply.
Sophia, any thoughts?
I'll just maybe build a little bit on kind of a few of the points that everyone's sort of mentioned. And I think, you know, we have really got a pretty good idea, even with there are a lot of data limitations. I think like just broadly, we could say that we need more data, which is a bit of a kind of academic-y thing to say, but, you know, we do need more data, particularly on youth who experience incarceration and sort of what happens to them after being released. And also, you know, the impact of certain types of interventions really could be better established in so supporting our ability to then implement them. But, you know, we have a pretty good idea about the fact that our systems aren't really working that well for particularly people who have experienced incarceration and especially Indigenous people who are much more likely to experience incarceration compared to non-Indigenous people. But, you know, the system's not working for all of us. And so, you know, if we're thinking about, you know, addressing anti-Indigenous racism in the healthcare system, then that needs to translate across some of the other systems. And I think an increasing appreciation of the fact that, you know, decolonizing some of these types of systems would actually not just benefit Indigenous people, but it would benefit non-Indigenous people as well. Because I think that more decolonial approach is more about, you know, being centered on the person rather than centered on the system. So I think, you know, really acknowledging that this current kind of colonial approach doesn't actually work for any of us is kind of a good place to start. But also really thinking about how do we embed people with experience in these systems into our teams so that it's not something that is then dependent on, you know, individuals like us who have these really good kind of relationships to continue to doing that, but it's more something that's actually kind of like routine and maybe like almost mandated in a way. I don't want to say that it should be forced because I think that risks it being kind of, you know, potentially tokenistic, but, you know, I think we should be thinking about how do we get to that point.
And how our criminal records follow us for life. Like we don't let it go. You know, I mean, 17 years later, you know, it still comes up, you know, I can't get a record seal because, you know, I have 3 indictment charges, right? So that stays with us, you know, and it does affect your housing because people want criminal record checks before they'll rent to you. They want, credit tax and, you know, all this stuff. So we're putting more and more barriers. And again, more and more people are going to end up not being able to get a job, not be able to get housing. So we're just going to, it's just this cycle. We make it so hard for people to get out of this life, where I think we need to do better as well.
Yeah, also with our educational institutions. So encouraging people who have been incarcerated to go back to school and to pursue post-secondary. And when we do ask those questions about, do you have a criminal record? I know the health authorities ask these questions for like the account, creating user accounts. And it's kind of like, but why are we asking those questions? Like what is the purpose of them? We do have a question from the audience around why don't we have hospitals or healthcare facilities to provide long-term care or help for people who have been or are incarcerated? And I'm just wondering, maybe the panelists have some thoughts around how the health system outside of corrections could be leveraged, or opportunities within the health system to support people who are leaving custody.
Yeah, look, I would just say, I mean, I know at least with the Australian data, and I don't think it's that different here in Canada, people released from prison show up at the hospital much more than the general population. So I'm not sure that hospitals are the solution. What we want to do is empower people to be well. And you know, I guess hospitals are much better than prisons, but swapping one institutional setting for another, you know, we need to have hospitals. But I would suggest that what we need to be doing is supporting people to be well, rather than providing long-term care for ill health.
Yeah, and from a public health perspective, prevention is always better than a cure. And we know that for a lot of individuals who've experienced incarceration, who have complex mental health and substance use needs, they've experienced trauma throughout their lives. And if we're actually looking at you know, preventing some of these kind of downstream impacts, we need to be looking at how do we ensure that people actually don't get exposed to those things in the first place. So, you know, really looking at the social determinants of health is actually likely to kind of be the most effective way of addressing these things.
And also this population, it's the last thing they want to do is go to a hospital, right? The way they're treated is disgusting. You know, even when if I take a client there, the way they get talked to and treated, you know, I think that's why, you know, like the community I live, like we have, you know, nurses that go out and do wound care, because that's the only time these people are actually getting medical care, right? Because they won't go to the hospital. So again, I think people rather go to jail than actually a hospital. And that says a lot about our hospitals, right? So we really need to change that shift to the way we're treating people, what go into our hospitals who need help, and not treat them like they're just, you know, a piece of garbage. And that still happens.
Absolutely. So I am mindful of the time. I'd like to thank our 4 panelists for joining us today for the Health After 2020 dialogue. And I will turn it over to Sarah to close us out.
Well, please feel free to put your thank yous in the chat for our wonderful, all of our experts who are here. I want to say miigwech. I want to hold my hands up to each and every one of you who are here. And I want to really congratulate each and every one of you for taking an interest in equity in healthcare, and especially for those that are the least served and, quite frankly, the least deserving of these kinds of horrific treatments by systems, by agencies like, you know, hospitals, the police, even in the incarceration. Guards are often, you know, severely racist people. So I just want to give thanks for everybody's expertise and to remind each and every one of you that you're deadly, and to give thanks for all the work that's being done to decolonize science, education, and to support those like Unlocking the Gate who are in the trenches. And to ask questions from people who know more than us is always the way forward to bridge our perspectives and our humanity. So I give thanks. I feel so inspired. I hope everybody here does too. Like, there's hope. And that's one of the most beautiful things that I heard here today, is we need to have hope. And as a 51-year-old auntie, I never thought I'd be here today to be able to witness the kinds of amazing work that's happening to make the changes that our next 7 generations can live with, and feel grateful and proud of us for deciding to have these uncomfortable conversations. So I hold my hands up to each and every one of you. Let's remember to be of service and to be kind, especially to those that are houseless, especially to those that are BIPOC or of the global majority and living under white supremacy, and to femmes and to trans and to queer people. We especially salute you for your righteous and consistent advocacy to be treated like a human being. All my relations.